Ever felt that heavy, tired sensation in your legs? Or maybe noticed some unusual changes in your skin down there?
It's surprisingly common, actually.
Yeah, it is. Today on the Deep Dive, we're tackling a really common issue that might be behind those experiences. Venous disease and the leg ulcers it can sometimes cause.
Right.
You shared a ton of information with us, really everything from how your veins work, the basics, all the way up to the latest ways to treat problems.
It's a lot to take in, definitely.
It is. So our goal isn't just to, throw facts at you, but to really unpack the important stuff, connect the dots so it makes sense, and give you a clear picture of what you need to know about venous disease and specifically venous leg ulcers.
Exactly. We want to make it understandable.
And we'll be using excerpts from Wound Care Essentials, Practice Principles, as our expert guide today. So let's get started by looking at the system that's, well, at the heart of this, your venous system. We all know arteries carry blood away, but what about the journey back to the heart?
Well, the venous system is what handles that return trip. Think of it starting small, with tiny venules joining into smaller veins, and those then merging into larger veins as they head back towards your core.
Okay.
Interestingly, while it has some similarities to the artery system, the vein system has a lot more variability in how it's laid out from person to person.
Yeah, I found this detail really interesting. In your lower leg, the veins that run alongside the tibial and peroneal arteries, they often come in pairs and have this sort of crisscrossing net-like look. The source calls it a rhetia appearance.
That's right. And these smaller veins eventually combine to form the popliteal vein, which is a major vein located right behind your knee.
Okay.
As it travels up your leg, it becomes the femoral vein. Now, this is where the name gets a bit tricky, as you pointed out.
Right, the superficial femoral vein, which sounds like it should be near the surface, but it's actually deep, isn't it?
Yeah, exactly. That's a really important point to clarify. So this superficial femoral vein, which is deep, then joins up with the deep femoral vein, and that one does drain the deeper part of your thigh to form the common femoral vein.
Got it. And you can actually see this whole, deep and superficial network laid out in Figure 15.1 in the material you shared.
Yeah, it's a helpful visual. And that brings us to the idea of this two-part venous system in your leg. The deep system we've just talked about, and then the superficial system, which is mainly made up of the saphenous veins.
Okay, let's focus on the main players in that superficial system. First off, the greater saphenous vein, or GSV. Where exactly does that one run?
So the GSV travels along the inner side of your leg, what we call the medial aspect. It starts down in the veins on the top of your foot, the dorsal digital veins, and passes just in front of and below that bony bump on the inside of your ankle, the medial malleolus.
Okay, that bump on the inside ankle bone.
That's the one. From there, it goes up your leg. Its path can vary a little, and sometimes it even branches into 2 or 3 smaller veins, which is interesting. Around the level of your knee, it goes a bit deeper into a space called the saphenous compartment, closer to the skin.
Right.
Finally, it connects with the common femoral vein up in your groin at an area called the fossa ovale. So it's a really long vein running pretty much the whole length of the inside of your leg.
And the other key superficial vein is the lesser saphenous vein. What's its job?
The lesser saphenous vein's main role is to drain blood from the back of your calf. It then goes deeper into the tissues behind your knee in the popliteal fossa and joins the popliteal vein there.
Okay, so we have these two main systems, deep and superficial. How do they talk to each other? How does blood get from, one to the other?
Good question. They're connected by what are called perforator veins. Think of these as little connecting roads, shunts almost, that move blood from the superficial veins, especially that greater saphenous system, into the deeper veins of your leg.
Perforator because they go through tissue.
Exactly. They get their name because they literally perforate or pass through a layer of connective tissue called the superficial fascia. The exact location of these perforator veins can differ somewhat between individuals, and some even have specific names.
Okay.
And interestingly, the material you shared mentions that the lowest perforator vein connecting these two systems is located just above that medial malleolus, that inner ankle bone we talked about earlier.
Now, all this upward flow, it seems like gravity would just pull it all back down. What stops that from happening and keeps the blood moving towards the heart?
Right, that's where the valves come in. They're crucial. Both the deep and superficial veins, as well as those perforator veins, are equipped with one-way valves.
One-way doors, basically.
Precisely. These valves are strategically placed just before the veins branch off. The GSV, for instance, typically has around 6 to 8 of these valves, and there's almost always one right below where it joins the common femoral vein. The way these valves are oriented ensures that blood can only flow from the lower parts of your feet and lower leg up towards the higher parts of your thigh and eventually your heart.
In the perforators.
In the perforator veins, the valves are specifically positioned to direct blood from the superficial system into the deep system. So yeah, they're like little traffic controllers ensuring one-way flow, always moving blood towards the core and from superficial to deep.
So what do these valves actually look like, and how do they manage this vital job?
Well, each valve is a bileaflet structure, meaning it has two little flaps or leaflets, and at the base of each flap are small pockets called valve sinuses.
Sinuses, like in your nose.
Hey, similar name, different function. These sinuses are key to how the valve closes. When blood tries to flow backward, you see it fills these sinuses, which pushes the two leaflets together, sealing off the vein and effectively blocking any reverse flow. The leaflets themselves are oriented parallel to the surface of your skin.
Clever design. But it's not just these valves working alone, is it? I remember reading about the calf muscle pump. How does that fit in?
Oh, it's absolutely vital. Think of your calf muscles contracting every time you take a step or flex your foot as actively squeezing the deep veins in your leg.
Like squeezing a tube of toothpaste.
Kind of, yeah. Because these muscle compartments are enclosed in a relatively rigid layer of tissue called fascia, this squeezing action significantly increases the pressure inside the deep veins. It can shoot up to around 200 millimeter Hg.
Wow, that's quite a bit of pressure.
It is, and this surge of pressure pushes the blood upwards. And those competent valves we just talked about, they prevent the blood from simply flowing back down when the muscles relax. So the muscles and the valves work together as a really efficient pump.
But what happens when these valves stop working properly? The source mentioned a few reasons why that might happen.
Right. When the valves become faulty, damaged, or incompetent and can't close properly, it leads to a condition called venous insufficiency, which is shown nicely in figure 15-2.
And that leads to problems.
Big problems. This loss of valve function can happen for a number of reasons, including being born without valves, which is rare, or damage from a deep vein thrombosis, DVT, a condition called ectasia, where the veins become abnormally widened.
Like stretched out.
Exactly, stretch out. Also, inflammation of the veins, phlebitis, a rare issue called valve atresia, where the valves don't develop correctly, or even just ongoing high pressure in the veins, what we call venous hypertension, and stiffness in the ankle joint can contribute.
Okay.
Interestingly, the material also points out that even if a vein just gets overly stretched, maybe from prolonged pressure, it can cause the valve leaflets to no longer meet properly in the middle, leading to incompetence.
So the structure of the vein walls themselves must also be important, or are they built like arteries?
Well, they share the same three basic layers, the adventitia on the outside, the media in the middle, and the intima on the inside. But a key difference is that the layers, especially the middle layer, the media, are generally thinner in veins compared to arteries.
Thinner walls, okay.
Right. The media in veins has significantly fewer elastic and muscular fibers. Despite this, veins can still contract and adjust their size somewhat in response to blood flow. The innermost layer, the intima, is just a delicate single layer of cells.
And this thinner middle layer, that affects how veins handle pressure, doesn't it? I remember reading something about venous compliance.
Exactly. Because that middle layer is thinner, veins are, well, less rigid at higher pressures compared to arteries. At lower pressures, the venous system is very compliant, meaning it can easily expand to hold more blood. It's like a reservoir.
A reservoir, okay.
But once the pressure gets up to arterial levels, the vein walls become much more stretched and less able to expand further. They're sort of at their limit. Interestingly, veins can also actively constrict, a process called venoconstriction, which is controlled by your sympathetic nervous system.
So they can tighten up.
They can. And veins further away from the heart are actually more sensitive to this control. This flexibility to expand and contract is important because it allows your veins to hold a huge amount of blood, around 75% of your total blood volume, in fact.
Wow, 3/4 of your blood is in your veins at any given time.
Roughly, yes. And it's easy to say how problems can arise if that blood doesn't get moved along properly. The source even gives that classic real-world example with military recruits fainting if they stand perfectly still for too long.
Right, because the muscle pump isn't working.
Exactly. Without movement, gravity just causes blood to pool in the lower legs, reducing the amount of blood returning to the heart. This can lead to a drop in blood pressure and, well, potentially fainting.
So just to quickly recap how blood gets back up the leg against gravity, it's a team effort involving those one-way valves, a little bit of help from arterial pressure pushing behind it, but mostly relying on the power of that muscle pump in your calf.
Precisely. And the pressure in these veins really changes depending on whether you're lying down, standing up, or moving.
How much does it change?
Well, when you're lying down, the pressure in your leg veins is pretty low, similar to the pressure in your central veins. But when you stand up, gravity kicks in and significantly increases that pressure. It can get up to around 100 millimeter Hg just from standing.
Okay.
Then, when you actively contract your calf muscles, like when walking, that pressure inside the muscle compartments can surge to about 200 millimeter Hg, effectively pushing the blood upwards past those valves.
Okay, so we have a good grasp of how the venous system is supposed to work. Now let's get into the problem we're focusing on. Venous ulcers. What exactly are they?
Right. Venous ulcers are basically chronic wounds, sores involving the skin and the tissue just underneath it, the subcutaneous tissue, and they typically occur on the lower leg.
Whereabouts on the lower leg, usually?
You'll often find them in the front of the shin area, which we call pretibial, and just above the inner ankle bone in the medial supramalleolar area. This location is important because it often corresponds to where those perforator veins we talked about earlier are located.
Okay, makes sense. Now, the source mentions they used to be called venous stasis ulcers. Why the name change?
Yeah, that older term stasis suggested that the ulcers were simply due to blood pooling or stagnating in the veins, kind of sitting there.
Right.
But we now understand that the primary driver is actually chronic venous hypertension that sustained high pressure in the veins rather than just the pooling of blood. And this high pressure is also a major reason why these ulcers can be so difficult to heal.
So it's not just about closing the wound.
Not at all. You absolutely have to control the underlying swelling, the edema that comes with that high pressure.
And it sounds like a deep vein thrombosis, a DVT, can really set the stage for these ulcers to develop, maybe even years down the road.
Absolutely. A DVT is a major risk factor for developing venous ulcers. The material you shared even suggests that the sort of natural progression of a DVT in the lower leg was once thought to almost inevitably lead to leg ulcers later on. And even if a DVT isn't diagnosed at the time, maybe it was asymptomatic or mild, it can still cause long-term damage that leads to issues years later.
How does a blood clot from way back then lead to an ulcer now? What's the connection?
Well, the blood clots, or thrombi, can cause scarring on the inner lining of the vein, the intima. But, critically, they can damage those delicate valves, leading to valvular incompetence.
So the valves get leaky.
Exactly. They can no longer effectively prevent blood from flowing backwards, especially during the relaxation phase of the heart diastole. Furthermore, if the valves in those perforator veins fail, the high pressure generated in the deep leg compartments during muscle contraction, that 200 millimeter Hg we mentioned, can then get transmitted out into the superficial venous system, causing it to expand or distend.
The domino effect, kind of.
It really is. This can cause the greater saphenous vein to dilate, further worsening the already compromised valve function and ultimately increasing the pressure right down in the tiny blood vessels, the capillaries in the skin.
Okay, so we had this picture of high pressure and faulty valves leading to these ulcers. What do they actually look and feel like? What are the key characteristics we should know about?
Well, that sustained high pressure in the veins causes the superficial veins to become distended, stretched out, and this can actually damage their walls. This damage allows fluid to leak out into the surrounding tissues, causing that typical swelling or edema you see with venous insufficiency.
Right, the swollen ankle.
Exactly. And over time, red blood cells can also leak through these weakened veins. As these red blood cells break down in the tissue, they release iron-containing pigment called hemosiderin.
Hemosiderin.
Yeah, and it gets deposited in the tissues, leading to a characteristic brownish or rust-colored discoloration of the skin. The source calls it internal tattooing, which is quite descriptive. It can be noticeable even in people with darker skin tones, as shown in figure 15-4.
That sounds like a really clear visual clue.
Yeah.
What other skin changes might someone notice?
The skin in the affected area often loses its normal soft texture. It can become somewhat shiny at first, and then it tends to get hardened and thickened, a condition we call sclerotic.
Hardened skin. Okay.
Right. This makes the skin look tight and stretched, and it also loses its elasticity, its stretchiness. Because there's also a loss of collagen in the upper layers of the skin, it becomes quite fragile and can break down easily, even with minor bumps or scrapes, forming an ulcer.
And location matters here, right? Usually around the ankle.
Yes, due to gravity, these changes and the ulcers themselves are usually most pronounced around the ankle area, which is the point of greatest gravitational pressure.
So the ankle is really a key area to watch. What other signs or features are common?
Well, key features include that hyperpigmentation from the hemosiderin and what's called stocking distribution, induration of the subcutaneous tissues.
Stocking distribution.
Yeah, it means a hardening and thickening of the tissue in a pattern that resembles where a stocking would be on the lower leg. It's a hallmark of long-standing venous insufficiency, a condition known as lipodermatosclerosis.
Lipodermatosclerosis. That sounds serious.
It is, and these areas become much more susceptible to both ulceration and infection. Patients often experience intense itching or pruritus, and the scratching or excoriation can further damage the already fragile skin.
So itching is a big symptom too.
Very common. Various types of dermatitis, inflammation of the skin, can also pop up both from internal causes related to the vein issues and external causes like allergic reactions or contact dermatitis from lotions, bandages, or even friction. The skin itself might appear itchy, red, and either weeping fluid or looking dry and scaly, as illustrated in figure 15-5.
It sounds incredibly uncomfortable. Are there any other related issues besides these skin changes?
Yes, definitely. The persistent high pressure in the veins can also affect the muscles. Many people, even with relatively mild venous insufficiency, report experiencing nocturnal leg cramps, those cramps at night.
Oh, interesting connection. Why does that happen?
It's thought that it might be due to a change in the electrical activity of the muscle cells caused by the fluid buildup distorting them. You might also observe obvious distension of the veins just under the skin, resulting in varicose veins, which figure 15-6 shows clearly.
Right, the bumpy, ropey veins.
Exactly. And the appearance of telangiectasias, those small web-like networks of dilated capillaries we often call spider veins, as seen in figure 15-7, is also very common.
In more severe cases, are there other potential complications we should be aware of?
In some instances, the greater saphenous vein and its branches can become massively dilated, leading to what are called venous aneurysms.
Aneurysms in veins, like in arteries.
Yeah, similar concept of bulged or dilation. The slower blood flow in these abnormally widened vessels, especially if the vessel wall is also weakened, can increase the risk of thrombophlebitis, which is inflammation of the vein, along with a blood clot forming inside it.
That sounds painful.
It can be, and this further obstructs the flow of blood out of the leg and makes the overall condition worse. These blood clots can stick to the vein wall, and even if the vein eventually reopens, the valves often remain permanently damaged. To compensate for the reduced venous return, the surrounding smaller veins, called collateral veins, can also widen. This contributes to chronic swelling around the ankle.
So it's just a whole cycle of problems.
It really is. The increased pressure in the veins hinders the flow of blood through the tiny capillaries, reducing the oxygen supply to the tissues. This causes proteins and red blood cells to leak out into the surrounding spaces. This ongoing process eventually leads to tissue damage, scar tissue formation, and ultimately ulceration. It's a cascade.
It really sounds like it. The source even mentioned something about endothelial dysfunction in varicose veins. What does that mean exactly?
That's an interesting point about the underlying biology. The endothelium is the inner lining of healthy blood vessels, including the saphenous veins. Normally, this lining plays an active role, helping the veins contract in response to certain signals, like a substance called noradrenaline.
Okay.
However, in varicose veins, this ability of the endothelium to help the vein contract seems to be reduced. Damage to the endothelium is thought to potentially play a role in the initial widening of the veins and the subsequent development of varicose veins. It's part of the disease process itself.
And is there a way to actually measure this pressure problem directly? The source talks about ambulatory venous pressure, or AVP.
Yes, exactly. Studies have shown a very strong link between this ambulatory venous pressure, the pressure measured while walking, and the presence of venous leg ulcers. One really important study by a researcher named Nicolaides found that none of the patients with an AVP below 30 millimeter Hg had leg ulcers.
None at all.
None below 30. But on the flip side, a very high percentage, basically 100% of those with an AVP above 90 millimeter Hg, did have ulcers.
Wow, that's a stark difference.
It is. And interestingly, the likelihood of ulceration wasn't specifically tied to whether the problem was primarily in the superficial veins or the deep veins. It was the pressure itself.
So what does that tell us?
Well, it suggests that measuring AVP in patients with non-healing venous ulcers might help determine if they could potentially benefit from more advanced procedures, like maybe a venous valve transplant, which aims to lower that AVP to below that critical 30 millimeter Hg level.
That's a really insightful connection between the measurement and potential treatment.
hmm
Okay, so we have a good understanding of what venous ulcers are and their characteristics, but what are the current ideas or theories that try to explain exactly why they develop? The source touches on a few, some older and some more recent.
Right, understanding the why is key. Early on, back in 1917, a researcher named Hummins suggested that maybe the stagnation of blood, the stasis in those dilated veins in the skin, might lead to a lack of oxygen, anoxia, and eventually tissue death, causing the ulcers. Makes intuitive sense, right?
Yeah, seems logical.
Then, in 1929, Blalock made an interesting observation. Oxygen levels were actually higher than normal in varicose veins. This led to the idea that maybe there were abnormal connections between arteries and veins, called arteriovenous communications, or shunts, bypassing the capillaries.
So blood skipping the tissues.
That was the theory. However, a later study in 1972 using radioactive tracers actually disproved this arteriovenous shunting theory. So those initial ideas didn't quite hold up to scrutiny.
Okay, so those didn't pan out. What about the more modern theories, like the fibrin cuff theory? What's that about?
The fibrin cuff theory became quite prominent. It proposes that the sustained high pressure in the veins causes the tiny blood vessels in the skin, the dermal capillaries, to become overly stretched and leaky.
Leaky capillaries.
Right. This stretching then allows fluid and large molecules from the blood plasma to leak out into the surrounding tissue. According to this theory, a protein called fibrin, which is normally involved in blood clotting, precipitates or solidifies in the space around these capillaries, forming these microscopic fibrin cuffs.
Like little jackets around the capillary.
Exactly. And these cuffs were thought to act as a barrier, hindering the delivery of oxygen, nutrients, and important growth factors to the skin tissues. This, in turn, was thought to lead to inflammation, fibrosis or scarring, and ultimately ulceration.
Makes sense as a mechanism. Is it still main theory?
Well, it was influential, but it's worth noting that later research has questioned whether the presence of these fibrin cuffs around the capillaries actually has a significant impact on the healing of leg ulcers. So, while it was a prominent idea, its exact role is now less certain.
Interesting. And another theory mentioned is the white cell trapping theory. What's the main idea behind that one?
This theory focuses more on the role of white blood cells, specifically neutrophils. It suggests that the increased pressure in the veins slows down the blood flow and actually reduces the pressure difference needed to push blood effectively through the capillaries.
So sluggish flow in the tiny vessels.
Precisely. This sluggish flow then causes neutrophils to stick to the walls of the capillaries. These stuck white blood cells and the cells lining the blood vessels then interact and release damaging substances, like enzymes and oxygen-free radicals.
Damage from our own immune cells?
In a way, yes. This damage increases the permeability, the leakiness of the capillary walls, allowing even larger molecules like fibrinogen to leak out into the tissues. This whole inflammatory process is thought to be a major contributor to the development of lipodermatosclerosis, that hardening and thickening of the skin we discussed earlier. This theory has more current support than the fibrin cuff idea.
Okay, that makes sense. And finally, there's the trap hypothesis mentioned briefly. What does that suggest?
The trap hypothesis, which was proposed by Falanga and Eaglestein, suggests that when fibrin and other large molecules leak out into the tissues, they can essentially bind or trap growth factors and other important substances that are normally needed to maintain healthy tissues and promote healing.
So the healing factors get stuck.
That's the idea. However, the material you shared notes that there hasn't been significant new research to strongly support this specific hypothesis recently. It's also really important to remember clinically that the skin changes associated with lipodermatosclerosis can sometimes be mistaken for a bacterial skin infection called bilateral cellulitis, especially during acute flare-ups as shown in figure 15-8. They can look quite similar.
Yeah. That could be confusing. It's certainly complex with all these different ideas trying to explain exactly what's happening at the microscopic level.
Yeah.
Now, how do doctors actually categorize or classify venous disease? It sounds like there are different levels of severity involved.
Yes, and having a standard way to classify it is really important for communication and treatment planning. That's where systems like the CEAP classification come in. First, let's define chronic venous insufficiency, or CVI. It's basically a condition where the venous system isn't functioning properly due to those faulty valves we've discussed, sometimes combined with a blockage in the outflow of blood from the veins.
Can it affect both systems, deep and superficial?
Yes, it can affect the superficial veins, the deep veins, or both. CVI can ultimately lead to what's known as post-phlebitic syndrome, which includes symptoms like varicose veins, swelling, skin changes, and eventually venous ulcers.
Okay, so how does CEP help classify this?
To better understand and communicate about chronic venous disease, the American Venous Forum developed the CEAP system. It's an acronym that stands for Clinical, Etiologic, Anatomic, and Pathophysiologic.
CEAP.
Right. It's designed to be an objective way of classifying the disease that helps clarify the different factors involved, what the signs look like, clinical, what caused it, etiologic, where the problem is located, anatomic, and what the underlying functional problem is, pathophysiologic.
Yeah.
It really improves communication among healthcare professionals.
So CEAP provides a framework. How is it actually structured? What are the categories?
The CEAP system has 7 main clinical categories, C0 through C6, based on the observable signs of chronic venous disease. You can see these detailed in Table 15-1 in your materials. It was updated back in 2004 to include that C0 category, which means there are no visible or palpable signs of venous disease. The person might have symptoms, but nothing shows up on exam yet.
Okay, so C0 is basically no visible signs.
Right. They also added more detail to the clinical component, particularly for the more advanced stages. For instance, the C4 category, which involves skin changes, was divided into C4A, indicating skin pigmentation or eczema, and C4B, indicating lipodermatosclerosis or atrophy blanche.
Atrophy blanche. What's that again?
That's a type of distinctive white scar-like tissue that can appear. So this more detailed classification helps clinicians describe the specific clinical findings more accurately, which is obviously helpful for guiding treatment decisions.
And the source also mentions another tool, the Venous Clinical Severity Score, or VCSS. How does that fit in with CEAP? Is it different?
The VCSS is sort of a companion to CAP. It was also developed by the American Venous Forum, starting in 2000 and revised in 2010, really as a way to add more detail and, importantly, track changes over time. While CAP gives a good snapshot classification, the VCSS aims to provide a more specific assessment of severity, especially for more advanced cases of chronic venous disease.
So it measures severity. How?
It includes 6 key descriptors, things like pain, the extent of varicose veins, edema, skin pigmentation, inflammation, and induration, that hardening. Each of these is rated on a scale from 0, none to 3, severe.
Okay.
Plus, it has 4 descriptors specifically for ulcers: the number of active ulcers, how long they've been present, their size, and importantly, the type of compression therapy being used.
And you said it tracks changes?
Yes, that's what's really useful about the VCSS. It's a dynamic score. It can change as the ulcers heal or as the underlying venous disease is treated or progresses. So combining the CEAP classification, which describes the what and where, with the VCSS, which describes the how bad and tracks progress, allows clinicians to not only describe the patient's condition objectively, but also to monitor how they're responding to treatment over time. It's a powerful combination.
That makes a lot of sense. Okay, so with all this understanding of the venous system, the problems and the classification systems, how do doctors actually go about diagnosing venous ulcers in a patient who comes in? What are the key steps they take?
Well, diagnosing venous ulcers really starts with the fundamentals: a thorough gathering of the patient's medical history and a careful physical examination.
History first.
Yeah.
What kind of things are important there?
A focused vascular history is key. This includes getting a clear description of the patient's current symptoms or complaint, asking about any past medical issues related to their blood vessels like previous DVTs and other relevant conditions like heart failure or diabetes. Also, getting a full list of all the medications they're currently taking or have taken in the past, and identifying any risk factors they might have for venous disease, like family history, obesity, or jobs involving prolonged standing.
Okay, history, meds, risk factors, then the physical exam.
Right. The physical exam focuses on signs and symptoms, looking for pain, tissue loss like an ulcer, and those characteristic skin changes we've discussed. But crucially, before we even think about treating a suspected venous ulcer with compression therapy, it's absolutely vital to assess the arterial blood flow in the legs.
Why is that so important?
Because applying compression to a leg that doesn't have adequate arterial blood supply can be dangerous. It can worsen ischemia. So adequate arterial flow is essential. That's where the ankle brachial index, or ABI, comes in.
ABI. We hear that term a lot.
Yes, and for good reason. It's a reliable, non-invasive test that can be easily done in a doctor's office, as shown in Figure 15-9. It compares the blood pressure in your ankle to the pressure in your arm. It should always be performed before starting any compression therapy.
And if the ABI is low?
If the ABI indicates significant arterial disease, those arterial issues might need to be addressed first, perhaps with revascularization, before compression for the venous problem can be safely applied. The material even includes a sample form for documenting this whole assessment in Figure 15-10.
Okay, so check the arteries first. What about tests for the veins themselves?
Right. Non-invasive vascular lab testing also plays a vital role. These tests help pinpoint the location and extent of any venous pathology, like where the reflux is happening or if there's an obstruction.
So the physical exam involves more than just glancing at the ulcer itself. What are some of the key things a doctor will be looking for and feeling for during that exam?
Absolutely. Careful inspection of the skin on both legs is critical. Doctors will be looking for those telltale skin changes we've discussed. Hypopigmentation, that brownish staining, any signs of dermatitis or eczema, lipodermatosclerosis, the hardening, and atrophy blanche.
Remind me about atrophy blanche again.
Right, as you can see in Figure 15-11, it's a very distinctive type of white, smooth, often star-shaped scar tissue that can appear in areas where previous ulcers have healed,
Oh.
or sometimes just in patches on the lower leg or foot. Table 15-2 provides a helpful comparison between the atrophy blanche seen with venous disease and a similar-looking condition called livedoid vasculopathy.
Okay. What else are they looking at?
The color of the skin gives important clues about blood flow. So the color of the toes should be noted and compared to the rest of the foot. In venous insufficiency, the skin might have a sort of dusky reddish or purplish hue, while in chronic cases it can become thin and fragile, sometimes with scarring, weeping fluid-filled blisters, or dry, scaly crusts.
And it's not just about how the skin looks, but also how it feels to the touch, right?
Right.
Temperature and texture.
Exactly. Palpation, feeling the skin and underlying tissues, is important. We assess for temperature changes. Is one leg warmer or cooler than the other? An infrared thermometer can also be used to detect significant temperature differences, say more than 3 degrees Fahrenheit, which might suggest underlying inflammation or even a deeper infection. The skin directly over varicose veins often feels warmer than the surrounding tissue.
Okay. What else are they feeling for?
It's also important to check for neuropathy, which is nerve damage, especially in patients who have foot or leg ulcers, as this is quite common in conditions like diabetes, which can coexist with venous disease. And of course, assessing for edema, that swelling in the leg, is a key part of the exam. Early edema might just be noticeable as a difference in the circumference of the calves between the two legs, which should always be confirmed with measurements.
And if the swelling has been there a long time?
In cases of long-standing edema, the tissues can become fibrotic, scarred down almost. This makes the skin and the tissue beneath it feel less springy or resilient when you press on them. It doesn't pit as easily.
So patients might come in describing certain sensations or symptoms that point towards venous problems. What are some of the common things they might report feeling?
Often, patients describe a gradual onset of discomfort rather than a sudden sharp pain. It's frequently a sort of general aching or feeling of fullness, swelling, tightness, or heaviness in their legs.
That heavy feeling sounds very characteristic.
It is, and they often find that these symptoms get better when they elevate their legs. That's a key clue. However, if the venous insufficiency is accompanied by an acute, recent DVT, the pain can be much more intense, often described as sharp, severe, and deep.
What about the varicose veins themselves? Do they hurt?
Sometimes, varicose veins might occasionally cause a localized pulling, prickling, or tingling sensation along the course of the vein. In really severe cases of venous insufficiency, some patients can even experience a type of claudication pain or cramping in the calf with walking, similar to arterial claudication but caused by venous congestion. And they might notice that swelling in their feet makes it difficult to wear their usual shoes.
Okay. And when a doctor actually examines an active venous ulcer, what are some of its typical features? How does it look?
A typical venous ulcer is often moist, maybe even weeping, and might have a yellowish, fibrous layer covering its base or surface, as you can see in Figure 15-12. It's really important for patients and clinicians to know that this yellowish layer, called fibrin slough, doesn't necessarily mean the ulcer is infected and doesn't usually prevent healing if managed properly.
Good to know. What about the shape and the surrounding skin?
The edges of the ulcer are often irregular in shape, not punched out like some other types of ulcers. The skin immediately surrounding the ulcer frequently feels firm, thickened, or hardened, what we call indurated. And as we mentioned earlier, that surrounding skin might have that characteristic brownish rust color due to the hemosiderin deposits.
Can you tell someone's had one before?
Often, yes. The presence of scar tissue in the typical ulcer area, particularly that atrophy blanch, is a strong indicator of a previous ulcer. And because of that underlying scar tissue, the skin in that area doesn't have the normal ability to stretch and accommodate swelling. Plus, the scar tissue itself can impede blood flow and oxygen delivery, which unfortunately makes the area more prone to reulceration and slows down healing if it does recur. And remember, lipodermatosclerosis, that chronic inflammation and fibrosis, that can also cause quite painful swelling in the area, as we saw back in figure 15-8.
So the history and physical exam provide a ton of important information, but it sounds like vascular testing is often essential to really confirm the diagnosis and understand the full extent of the problem. What are some of the key vascular testing methods that are used?
You're right. While an experienced clinician can often get a very good idea of the diagnosis based just on the history and physical exam, adding vascular laboratory studies really helps to confirm the presence, location, and severity of both arterial and venous disease.
What else can these tests tell us?
Well, this information can even help predict whether an ulcer that might have an arterial component is likely to heal. Lab tests are also crucial for distinguishing between different underlying conditions that could be contributing to an ulcer that just isn't healing as expected.
Okay. What kinds of tests are we talking about?
Non-invasive vascular testing can be broadly divided into direct tests that actually create an image of the blood vessels themselves, and indirect tests that look for changes further down the limb that are caused by the diseased vessel upstream. These tests range from relatively simple bedside assessments, like using a handheld Doppler ultrasound and measuring the ABI, to more complex studies performed in a vascular lab, like duplex ultrasound, transcutaneous oxygen pressure, TCPO2, segmental systolic pressures, and various forms of plethysmography.
Let's break down a few of those. What specific information does a simple Doppler ultrasound provide in this context? How does it work?
In a basic Doppler ultrasound, a handheld probe emits sound waves at a specific angle towards the blood vessel. When these sound waves hit moving red blood cells, they bounce back to the probe, but their frequency is slightly shifted. That's the Doppler effect.
Okay.
The device detects this frequency shift and converts it into an audible signal, usually a whooshing sound. By listening to these signals, experienced doctors or technicians can distinguish between the characteristic flow patterns of healthy arteries and veins and detect abnormal flow like reflux in veins. It's a quick and easy way to get a basic assessment of blood flow.
And duplex ultrasound, you mentioned that earlier. How does that provide more information than a regular Doppler?
Duplex ultrasound is a step up because it combines traditional B-mode ultrasound imaging, which creates a picture of the structures, with Doppler technology that assesses blood flow. This means the examiner can actually see the veins their size, whether there are clots inside, and at the same time measure the speed and direction of blood flow within them.
So you get a picture and the flow data.
Exactly. Specifically for venous insufficiency, they'll be looking for reflux, that backward flow of blood lasting for more than half a second after either a calf muscle squeeze or manual compression further down the leg to push the blood upwards. A major advantage of duplex ultrasound is its very high accuracy in identifying blood clots or thrombosis. And the detailed findings about where the venous reflux is happening can directly influence the choice of treatment, like deciding which specific veins need to be targeted.
Sounds very useful. Any downsides?
Well, it's a more detailed test, and it can take a bit longer to perform, often around 1 to 2 hours, to fully evaluate all the major deep and superficial veins in a single leg.
The source also mentions using just a Doppler probe for a crude venous assessment. What does that involve? Is it reliable?
Yeah, this is a much simpler technique. The examiner manually compresses the limb, say squeezing the calf, and then listens with a Doppler probe placed over a vein further down the leg. If the veins and valves are working correctly, this compression should temporarily increase the forward blood flow, producing that characteristic swishing or augmenting sound.
Okay.
However, this is a much more subjective assessment, and how reliable it is really depends heavily on the experience and skill of the clinician performing it. The more sophisticated non-invasive vascular tests like duplex have really given us a much clearer and more objective picture of what's happening anatomically and physiologically in the veins.
Now, let's talk about plethysmography. That sounds like a more involved procedure. What kind of information does that give us?
Plethysmography is basically a technique that measures changes in the volume of a limb, which indirectly reflect changes in blood flow. There are several different types. Air plethysmography uses a pneumatic cuff, like a blood pressure cuff, wrapped around the limb to detect volume changes based on changes in air pressure within the cuff. Strain gauge plethysmography uses a thin, flexible tube filled with mercury or another conductive material wrapped around the limb. As the limb volume changes, the tube stretches, changing its electrical resistance. Impedance plethysmography measures changes in the electrical resistance of the limb itself as blood volume fluctuates. And photoplethysmography, or PPG, uses light, usually infrared shown onto the skin, to assess the relative amount of blood present in the superficial capillaries. It doesn't directly measure volume, but rather blood content in the skin.
Which of these are most common for venous issues?
For assessing chronic venous disease, air plethysmography and PCG are the more commonly used types. PPG, which uses that infrared LED and a photosensor placed on the skin probe, is a particularly quick way to get an overall assessment of venous refill time after exercise or calf squeezes. A faster refill time generally indicates more severe reflux. However, a limitation is that it typically only evaluates the most dependent part of the leg, often the area around the ankle known as the gaiter area.
Okay, so we have a much better understanding now of how venous ulcers are diagnosed, from the history and exam right through to these specialized tests. Now, let's move on to the really important part, treating them. What are the general principles of treatment? What's the overall approach?
Right, treatment. The fundamental principle, the absolute cornerstone in treating venous leg ulcers is that you must address the underlying venous disorder, primarily the venous hypertension. You can't just treat the hole in the leg, you have to fix the plumbing problem, so to speak.
Makes sense. So how do you address that underlying problem?
Reducing the swelling, the edema, is paramount. This is achieved through a combination of compression therapy, elevating the legs whenever resting, and maintaining an active exercise routine to help that calf muscle pump work effectively. These are all essential parts of the ongoing management of venous disease.
And the goals for the ulcer itself.
The main goals when treating any wound, including venous ulcers, are pretty straightforward. You want to create an environment that encourages the growth of healthy new tissue, you need to protect the fragile wound bed from further injury or infection, and you want to prevent any further tissue breakdown.
Can you use different treatments at the same time?
Oh, absolutely. Both topical treatments applied directly to the wound, like dressings and systemic treatments, perhaps addressing infection or other contributing factors, might be used simultaneously. It's really critical, though, to consider what's causing the ulcer when deciding on treatment. Different types of leg ulcers need different approaches, and a treatment that helps a venous ulcer might not be effective or could even be harmful for, say, an arterial ulcer.
So if it's not clear if it's purely venous.
Right. If there's any suspicion that the ulcer might have both venous and arterial causes, a mixed etiology, it's highly recommended to consult with a vascular specialist to ensure the right diagnosis and treatment plan are in place.
Okay. One of the big concerns with any open wound is obviously infection. How is wound infection managed when dealing with venous ulcers? Are antibiotics always needed?
That's a really important question. For leg ulcers that show clear clinical signs of infection, things like increasing redness and spreading inflammation of the surrounding tissue, cellulitis, increased pain, warmth, maybe pus, or if there's suspicion of a bone infection, osteomyelitis underneath, then the standard treatment involves systemic antibiotics, given either intravenously or by mouth, depending on severity.
What about antibiotic creams or ointments?
Topical antibiotics applied directly to the ulcer are generally not recommended for routine treatment of venous leg ulcers. The evidence just doesn't support their effectiveness in this setting, and there are concerns about resistance and allergies.
What about bacteria that are just living on the wound surface?
Right. It's crucial to remember that virtually all chronic wounds, including venous ulcers, will have bacteria present on their surface. This is called colonization, and it's often just normal skin bacteria. These colonized wounds that don't show those clinical signs of active infection should not be treated with systemic antibiotics. Overusing antibiotics just breeds resistance.
So no need to try and sterilize the wound.
Exactly. And related to that, the old practice of vigorously and frequently cleaning ulcers, scrubbing them to try and remove all surface bacteria, is no longer advised. It can actually increase pain, which can persist long after the dressing change, and potentially damage fragile new tissue.
What about those silver dressings we hear about? Aren't they supposed to kill bacteria?
Yes, silver-impregnated dressings have been used quite a bit because silver does have antimicrobial properties. However, large reviews of studies haven't shown a significant difference in how quickly ulcers heal when using silver dressings compared to other types of non-silver dressings. So their routine use is not generally recommended based on current evidence, especially considering their higher cost. They might have a role in specific situations, but not as a default.
When might it be necessary to actually do a biopsy of the wound? You mentioned infection and maybe cancer earlier.
Right. A biopsy, taking a small tissue sample for bacterial culture and microscopic examination, should definitely be considered in a few situations. First, if a non-healing ulcer doesn't get at least 30% smaller in size within about 4 weeks of appropriate treatment starting.
Okay, lack of progress.
Exactly. Also, if it's still not healed after, say, 12 weeks, despite good care, or if there's suspicion of a deep wound infection like osteomyelitis, that isn't responding as expected to the antibiotics that have been prescribed.
And for ruling out cancer.
Yes, absolutely. A biopsy should always be done if the appearance of the ulcer is unusual, or if there's any clinical suspicion that it might actually be a type of skin cancer mimicking an ulcer. It does happen.
What about probing the wound? If you can feel bone.
Right. If bone is visible in the base of the wound, or if you can feel bone when you gently probe the wound with a sterile instrument, this is a very strong sign of potential underlying osteomyelitis, especially in patients who also have diabetes and foot ulcers. However, it's crucial to probe very carefully and know the underlying anatomy to avoid causing any injury to delicate tissues, nerves, or blood vessels.
Are bone scans helpful for diagnosing osteomyelitis?
Bone scans are sometimes used, but they have limitations. They can be expensive, and they might give false positive results if there's just inflammation or other bone changes present, not necessarily infection. Therefore, a special type of bone scan called a triple-phase bone scan is usually only ordered if there's a strong clinical suspicion of osteomyelitis that needs confirmation.
Okay, so keeping the wound clean is important for healing, but we need to be careful about what we use to clean it. What are some of the best practices for taking care of the skin and the wound itself with venous ulcers?
You've got it. A clean wound bed, free of dead tissue, slough or eschar, and debris, is absolutely essential for healing to occur. So wound cleaning and debridement, which is the removal of that non-viable tissue, are usually the very first steps in wound care.
But you said be careful what you use.
Yes, because many commercially available wound cleansers, and particularly disinfectants, can actually be harmful to the delicate healing tissues. They can be cytotoxic, meaning they damage cells. Substances like povidone iodine, betadine, hydrogen peroxide, and even dilute acetic acid have been shown in lab studies to interfere with the growth and function of fibroblasts, the cells that build connective tissue, and the migration of new skin cells, epithelial cells.
So things we used to think were good for cleaning might actually slow healing.
Potentially, yes, if used inappropriately on an open wound. While there might be specific limited situations where certain antibacterial agents, cytolytic agents, are indicated, their use should generally be time-limited, and the healthcare provider should have a clear goal for using them and know when to stop. The potential benefit of cleaning the wound must always be weighed against the risk of damaging that fragile new tissue that's trying to grow.
So what should be used for routine cleaning?
The safest, most physiological, and generally recommended wound cleanser is simple 0.9% sterile saline solution, normal saline.
Just salt water, basically?
Essentially, yes, at the right concentration. And how you apply it matters too. When irrigating or cleaning, the pressure should be just right enough to dislodge debris and bacteria, but not so high that it damages new tissue. The ideal pressure is typically considered to be in the range of 4 to 15 pounds per square inch, PSI.
How do you get that pressure?
A common way to achieve this in a clinical setting is by using a 19-gauge needle or a small angiocatheter attached to a 35 ml syringe, squirting the saline through that delivers roughly 8 psi. There are also commercial irrigation products specifically designed to deliver pressure within that safe and effective range.
What about for patients at home? Do they need sterile saline?
For patients managing leg ulcers at home, using clean, safe running tap water for irrigation is often considered acceptable and practical, especially if sterile saline isn't readily available or affordable. The risk of infection from potable tap water in this context is generally low.
What about hydrotherapy or whirlpool treatments? Are they still used?
Hydrotherapy or whirlpool treatments have historically been used sometimes to help clean and debride arterial and venous leg ulcers. One small pilot study suggested that rinsing the ulcer with saline after a whirlpool treatment might be beneficial in reducing bacteria, possibly indicating that it's the rinsing itself that's key, not necessarily the whirlpool. However, whirlpool therapy might actually be contraindicated, not a good idea, if it increases swelling edema in the leg, which it often can. And currently, there's just not strong enough evidence to widely recommend or discourage its routine use for cleaning venous ulcers. Other methods are generally preferred.
Okay. And what about dressings? There seem to be literally hundreds of different types available. How on earth do you choose the right one? Does it matter that much?
That's a great question, and it can definitely seem overwhelming. The type of dressing you choose really depends on the specific condition of the wound bed. Is it dry? Is it draining heavily? Is there dead tissue? And what your immediate treatment goals are for that wound at that time. A key principle for most wounds is maintaining a moist wound environment, which is known to promote healing.
Moist, not wet, not dry.
Exactly, a balanced moisture level. Now, because the skin in people with both arterial and venous disease can be extremely fragile and easily injured, adhesive tapes and products should be avoided whenever possible, or used very, very cautiously.
So how do you keep dressings on?
Non-adhesive methods like soft roller gauze, like Cling or Curlix, elastic netting, or tubular gauze, like Tubigrip, used carefully, are generally preferred for holding primary dressings in place over the ulcer and protecting the surrounding skin.
But does the type of dressing material itself make a big difference in how fast venous ulcers heal, as long as you have compression?
That's the million-dollar question. Interestingly, a major Cochrane review, which looks at all the best available evidence, found that the specific type of dressing material used underneath adequate compression therapy had no significant effect on how quickly venous ulcers healed.
Really, so all those fancy dressings might not be better than simple ones.
When used under proper compression for venous ulcers, the evidence suggests that might be the case. Similarly, other studies haven't shown any clear, consistent advantages with using silver-containing dressings or honey-containing dressings compared to simpler, less expensive standard dressings in terms of speeding up healing for most venous ulcers. So while specific dressings might have advantages for managing drainage or comfort, the core treatment remains the compression.
We've talked around compression quite a bit already. It really sounds like it's the absolute cornerstone of treating venous ulcers. Can you emphasize again why it's so crucial?
You're absolutely right to keep coming back to it. Compression therapy is, without a doubt, the fundamental, indispensable foundation of venous ulcer treatment and prevention of recurrence. It works by addressing both the underlying problem, the high pressure in the veins, venous hypertension, and by helping the wounds themselves to heal, primarily by reducing edema.
So it tackles the cause and helps the symptom.
Exactly. Managing that swelling, the edema, which is a key part of treatment, relies heavily on things like elevating the legs at intervals when resting, using compression bandages consistently, and sometimes using those intermittent pneumatic compression devices we mentioned.
And does compression speed up healing?
Yes, studies have clearly demonstrated that combining wound care techniques that promote a moist wound environment with adequate, sustained compression significantly speeds up the rate at which venous ulcers heal compared to wound care alone. When someone is resting, elevating their legs above the level of their heart is still recommended. But importantly, the current advice is to encourage people to be as active and mobile as possible while wearing their compression. Movement helps the calf pump work.
Do people wear compression all the time?
It depends on the type of system. If they're using compression stockings or garments, these are usually removed at night for sleeping and put back on first thing in the morning. However, if multi-layer compression bandages are used, they typically stay in place continuously, 247, until they are changed by the healthcare provider, which is often done weekly, sometimes twice weekly.
So how is this compression actually applied? And what are the different kinds of compression systems that are used? How much pressure is needed?
Right. Compression involves applying external pressure to the leg, and this pressure is measured in millimeters of mercury, mmHg, just like blood pressure. This pressure can be delivered using various systems, multi-layer bandages, elastic stockings, or those inflatable pumps, intermittent pneumatic compression, IPC devices.
How much pressure is right?
The amount of pressure that's needed depends on the individual's specific diagnosis, primarily venous, maybe mixed arterial venous, any other health issues they might have like heart failure or severe arterial disease, and importantly, how well they are able to tolerate and comply with the treatment plan.
Is there a standard classification for pressure levels?
Yes, there's a standard way of classifying the pressure delivered at the ankle. Mild is less than 20 millimeter Hg, moderate is 21 to 40 millimeter Hg, strong is 41 to 60 millimeter Hg, and very strong is 61 millimeter Hg or higher. For treating active venous ulcers, a pressure of 30 to 40 millimeter Hg at the ankle is often recommended to effectively counteract the high pressure in the capillaries and reduce edema.
What if someone can't tolerate that much pressure?
Good point. For older or more frail individuals or those who have significant difficulty putting on daunting high compression stockings, a lower pressure level, perhaps 20 to 30 millimeter Hg, might be prescribed initially or as a long-term option. Some compression is better than none.
Does the type of bandage or how it's put on affect the pressure?
Absolutely. It's important to realize that many things can affect the actual pressure achieved under a bandage. This includes the physical properties of the bandage material itself, its stretchiness, how well the patient's calf and foot muscles are working as pumps when they move, the shape and size of the person's leg, and critically, the skill and technique of the person applying the bandage. It's not as simple as it looks.
What type of compression works best for people who are up and walking?
For people who are ambulatory, able to walk, semi-rigid dressings like the traditional Una boot, a zinc paste impregnated bandage, or more commonly now multi-component, multi-layer compression wraps are often the most effective choices. Multi-layer systems, typically involving 2, 3, or 4 different types of bandages applied in sequence, have generally been shown to work better than single-component systems. And both 4-layer bandages and systems using short-stretch bandages tend to lead to better healing rates compared to the older approach of just a paste bandage plus an outer elastic support bandage.
You mentioned dressings underneath the compression earlier.
Yes. Keeping in mind the importance of that moist wound environment, occlusive or semi-occlusive dressings like hydrocolloids or foam dressings can be used as the primary dressing directly on the ulcer underneath the compression wrap system. These can help promote the growth of new granulation tissue, reduce pain by providing cushioning and minimizing friction, and also help the body naturally remove dead tissue through a process called autolytic debridement. One study even found that venous ulcers treated with a simple foam dressing placed under an Una boot healed twice as fast as those treated with the Una boot alone.
There are different kinds of bandage materials as well, right? You mentioned short stretch. What about long stretch or elastic? What's the difference there?
Yes, the bandage materials themselves have different properties. Elastic bandages are considered long stretch if they can stretch significantly, maybe to about twice their original length. They exert pressure even when the leg is at rest, resting pressure. However, because they can potentially be stretched too tightly if not applied expertly, they're usually not recommended as the only compression dressing for venous ulcers and are often best used as one component, usually the outer layer of a multi-layer system.
Okay, so long stretch needs care. What about inelastic?
Inelastic bandages, which include non-stretch materials, short stretch bandages, which have limited stretch, and paste bandages, like the Una boot, behave differently. The pressure under these bandages tends to decrease significantly when the leg is at rest. However, they provide very high pressure, called working pressure, when the muscles are active and pushing against the rigid bandage during walking or ankle movements. This high working pressure is very effective at assisting the calf muscle pump.
So the choice depends on the situation.
Exactly. The choice of which type of system or bandage material to use often depends on factors like patient adherence, the amount of edema, the presence of mixed disease, and certainly the healthcare provider's experience and skill in applying it correctly. Proper application technique is key for any system.
How should they be applied? Any key tips?
Compression wraps should generally be applied starting just proximal to the base of the toes, leaving the toes visible for checking circulation, and extending up to just below the knee, below the popliteal fossa, to cover the main calf muscle pump area. A primary dressing is typically placed directly on the wound first. Then the compression bandage system is applied over it, often in a spiral or figure-of-8 pattern.
What if the leg isn't a smooth shape?
Good question. If the leg has an irregular shape, particularly around the ankle, or if there are bony prominences, padding should be used strategically. Padding helps to create a smoother, more cylindrical surface, which allows the bandage to apply pressure more evenly, reduces the chance of the bandage slipping down, and prevents it from acting like a tourniquet in constricted areas, which could actually worsen swelling further down the leg. Extra padding over bony areas like the shin or ankles can also help prevent pressure injuries from the compression itself. The areas around the ankles, which can be quite concave, might also need extra padding to ensure enough supportive pressure is applied right where it's needed most.
Sounds like training is important.
Oh, definitely. Ongoing training and competency assessment for healthcare professionals who apply these bandages are really important to avoid potential complications. These can include applying ineffective pressure, too little or too much, causing pressure sores or skin damage, having the bandage slip down, bunch up, or distort the shape of the leg, as illustrated quite well in Figure 1513. Getting it right matters.
Are there any other potential downsides or complications that can arise from compression therapy, even when applied well?
Yes, even with proper application, some issues can arise. Potential complications can include pain, especially if there's underlying arterial disease or neuropathy, damage to the skin or the tissues beneath it if the pressure is too high or uneven, a decrease in calf muscle mass over time if the leg isn't used actively, though exercise is encouraged, and other skin problems like irritation, dryness, or allergic reactions to the bandage materials.
How are these managed?
Managing these potential issues involves carefully assessing and addressing any pain the patient reports, making sure that excessive pressure is avoided, especially over bony areas, strongly encouraging regular exercise and range of motion movements for the ankle and foot, and avoiding any topical products under the bandages that might irritate the skin.
What about compression stockings instead of bandages? How do they fit in?
Compression stockings work on the same principle. They help to lower the high ambulatory venous pressure by reducing that backward flow reflex in the superficial veins and by providing external support to improve how well the calf muscle pump ejects blood upwards. How much benefit you get from stockings really depends on getting the right size and pressure level and, crucially, wearing them consistently. There's very good evidence supporting their use as an active treatment for venous ulcers, often after an initial period of bandaging to reduce significant swelling.
But you hear people complain about them being hard to put on or uncomfortable.
That's definitely a major challenge. Adherence can be difficult. Many people, especially older adults or those with arthritis or limited mobility, find it very difficult to physically put on the higher pressure stockings. Others complain that they feel too tight or uncomfortable, particularly in warm weather. This can lead to them not wearing them as often or as consistently as they should.
So what can be done about that?
It's really important for healthcare providers to acknowledge these difficulties, but also to strongly emphasize the long-term benefits and necessity of wearing compression to prevent ulcer recurrence. Providing education, showing proper donning techniques, suggesting helpful donning aids like special frames or silk liners, and ensuring the correct fit and pressure level are all crucial. Patients should also be advised that stockings lose their elasticity over time and usually need to be replaced every 3 to 6 months. Having two pairs allows one to be worn while the other is being washed.
Is compression needed forever?
For individuals with established lymphedema and significant chronic venous disease, yes, lifelong compression therapy is often necessary to provide ongoing external support to the damaged vein valve structures in the leg and prevent the condition from worsening or ulcers from returning.
The source also mentions pneumatic compression pumps again here. How do those fit into the treatment plan for venous ulcers specifically?
Right. Intermittent pneumatic compression, IPC pumps, those inflatable sleeves that wrap around the leg and inflate and deflate sequentially, can be a useful adjunct therapy. They work primarily by helping to reduce edema, essentially milking the fluid out of the leg. Some studies have shown that using IPC devices can improve the healing of venous ulcers when added to standard care, although, as the source notes, not all insurance payers currently agree on covering them specifically for this purpose.
When might they be particularly helpful?
One study found that using a pump for 4 hours a day, in addition to wearing compression stockings, helped ulcers heal faster than stockings alone. Another small study showed that using an IPC device for just 1 hour twice a week along with standard dressings also led to better healing. These devices can be particularly beneficial for people who are not very mobile, those who cannot tolerate sustained compression bandages or stockings, patients who might have some mild to moderate coexisting arterial insufficiency, where high sustained compression might be risky, or those with particularly stubborn or severe edema problems. They are often used at home by the patient.
Okay, so with all these treatments, how do doctors know if the plan they've chosen is actually working? What are the signs of progress they look for when treating a venous ulcer? And what if it's not working?
That's critical monitoring progress. Generally, you expect to see some signs of healing within a few weeks of starting appropriate treatment, especially adequate compression. Signs include the wound getting smaller in size, surface area and depth, the amount of drainage decreasing, the wound bed looking healthier, more red granulation tissue, less yellow slough, and the surrounding skin looking less inflamed.
And if those signs aren't there? if the ulcer isn't healing?
If a venous ulcer isn't showing any clear signs of healing after, say, 4 weeks of good standard care, it's definitely time to reassess everything. This involves reevaluating the patient's overall health, their adherence to the treatment plan, especially compression. The accuracy of the diagnosis, is it purely venous, and the wound itself. As we mentioned, this is a point where considering a biopsy of the edge of the wound becomes important, primarily to rule out other possible causes like malignancy or vasculitis that might be masquerading as a simple venous ulcer.
Are there specific factors that are known to really slow down or prevent healing?
Yes, unfortunately, there are several factors that can significantly hinder venous ulcer healing. These include underlying systemic conditions like poorly controlled diabetes, congestive heart failure, which worsens edema, significant peripheral arterial insufficiency, reducing blood supply needed for healing, and end-stage kidney disease. Local factors are also key. Persistent, uncorrected venous reflux or obstruction, a history of previous thrombosis in the deep veins, critical colonization, a high bacterial load impairing healing even without overinfection, and any untreated deep infection like osteomyelitis. All of these need to be considered and addressed if possible.
And the source also highlights the important role that exercise can play, not just for prevention, but as part of the active treatment plan. Can you elaborate on that?
Yes, exercise is increasingly recognized as a vital component. There's good evidence supporting the incorporation of a structured, graded exercise program as an important adjunct to the standard care of venous leg ulcers.
How does exercise help specifically?
Well, it directly helps to improve the function of the calf muscle pump, especially in people who have dysfunction in that pump mechanism due to the venous disease itself or prolonged inactivity. A stronger pump means better venous return and less pooling. Additionally, exercise makes compression therapy more effective because the muscles are actively contracting and relaxing against the resistance provided by the bandage or stocking, enhancing that pumping effect.
So just walking more helps in
Yeah.
specific exercises.
Both can be beneficial. Simply increasing general activity and ambulation is good. But some studies have shown that structured exercise programs, perhaps involving specific calf strengthening exercises, ankle range of motion movements, and even supervised walking programs, can have a significant positive impact on healing rates and reducing recurrence in people with venous disease.
And does reducing the swelling help the skin itself?
Absolutely. Successfully reducing the edema in the leg through compression and exercise can actually help to reverse many of the associated problems, especially those troublesome skin changes like discoloration and hardening, although some changes might be permanent if they've been present for a very long time. The key, then, is to maintain that reduction in swelling long-term by using appropriately fitted compression hosiery or alternative compression products consistently.
Getting people to stick with it seems key.
It really is. As we discussed, compliance can be a challenge. Providing good education, ensuring proper fit, teaching patients how to use application aids, and sometimes getting creative in combining different compression products to achieve adequate pressure levels comfortably, all of these can help improve adherence. Ultimately, the patient's understanding and commitment to following the entire treatment plan, especially lifelong compression, is absolutely vital for preventing the swelling and ulcers from coming back again and again.
We've talked a lot about non-surgical treatments like compression, wound care, and exercise. What about surgical options for venous ulcers? When might those be considered, and what do they involve?
Right. Surgery comes into play when conservative measures aren't enough or to address the root cause more definitively. Surgical treatment for venous ulcers primarily aims to correct the underlying cause of the venous hypertension. It's important to remember, though, that some people can have significant venous reflux, that backward flow, without actually experiencing any symptoms or skin problems. So surgery is generally considered for those patients with more severe insufficiency that is causing significant symptoms, high pressure in the skin, dermal hypertension, and the skin changes or active ulceration we've been discussing.
What kinds of surgery are there? Are they focused on the deep veins or superficial veins?
There are procedures that target both systems. Procedures aimed at the deep venous system include things like vein valve transplantation, moving a healthy valve from elsewhere, direct surgical repair of damaged valves, and creating a new pathway for blood flow around a blockage in a deep vein, which is called venous bypass. Blockages in the deep veins, outflow obstruction, can also be addressed with these bypass procedures or increasingly with minimally invasive endovascular techniques like angioplasty and stenting, or sometimes a combination of approaches.
And for the superficial system, like varicose veins?
For superficial venous insufficiency, which often manifests as varicose veins and can significantly contribute to ulcers, treatment usually involves techniques to close off or remove the affected superficial veins, primarily the saphenous veins if they are incompetent. Options here include traditional surgical removal, ligation and stripping, tying them off, ligation, injecting them with a sclerosing solution to close them, sclerotherapy, or using heat-based and Venous ablation techniques like laser or radiofrequency to seal them shut from the inside. The choice depends on factors like which veins are affected, their size, and pacer factors.
It sounds like vein surgery might be a bit behind artery surgery.
That's a fair assessment mentioned in the source. Historically, surgical treatments for venous insufficiency haven't perhaps advanced as rapidly or become as standardized as treatments for blocked arteries, arterial occlusive disease, but there has been significant progress, especially with minimally invasive techniques in recent years.
The source breaks down venous insufficiency into two main problems leading to hypertension: reflux and outflow obstruction. Can you explain those again in the context of surgical treatment goals?
Sure. So venous reflux is when blood flows backward in the wrong direction down the leg because the valves are incompetent or damaged. Outflow obstruction is when something is physically blocking or significantly slowing down the flow of blood out of the leg veins towards the heart. Both of these problems ultimately lead to that sustained high pressure in the lower leg veins, venous hypertension, which is the main culprit behind the skin damage and ulceration. Surgical or procedural interventions aim to correct one or both of these underlying problems.
But compression is still key, even with surgery.
Absolutely. It's crucial to emphasize that the main approach to treating venous insufficiency and ulcers remains good external compression. This is often sufficient on its own as both a treatment and a way to prevent recurrence. Surgery or endovenous procedures are generally considered for patients whose symptoms or ulcers are not adequately controlled with compression therapy alone, or to potentially reduce the need for lifelong high-level compression in some cases.
What causes that outflow obstruction usually?
Venous outflow obstruction is most commonly caused by scarring or damage resulting from a previous deep vein thrombosis, DVT. But it can also be due to other things, like surgical removal of veins that inadvertently interrupts a major outflow pathway, tumors pressing on veins from the outside, scarring from radiation therapy, congenital abnormalities where veins didn't form correctly, damage from therapeutic injections, or even severe obesity combined with prolonged immobility. Infections can also sometimes lead to vein blockage. Blockages in one key part of the venous system can sometimes lead to a cascade of problems causing widespread venous insufficiency downstream.
How is outflow obstruction treated surgically or procedurally?
In cases where outflow obstruction is the primary problem, options might include creating a surgical bypass around the blocked segment using a graft, often another vein. Or, more commonly now, for obstructions in the larger veins like the iliac veins in the pelvis, using minimally invasive techniques like balloon angioplasty to widen the narrowed or blocked area, often followed by placing a metal mesh stent to help keep the vein open.
What about removing the clot itself?
If the blockage is due to a more recent blood clot, acute or subacute DVT, performing either traditional open surgery, thrombectomy, or increasingly using catheter-based minimally invasive procedures to remove or dissolve the clot might be considered. Treating iliac vein obstruction using these endovascular techniques, angioplasty and stenting, is now a fairly routine procedure in specialized centers. Intravascular ultrasound, or IVUS, which is an ultrasound probe on a catheter inside the vein, is often used during these procedures to get a very detailed picture of the blockage and guide the treatment accurately.
How successful are these stenting procedures?
While there can be a risk of the vein re-narrowing or the stent reblocking, particularly early on, the source mentions 35% reocclusion at 3 months in one series, the long-term success rates in terms of keeping patients ulcer-free can be quite good, potentially around 60% at 5 years in some studies. Early thrombosis or scarring within the stent, in stent stenosis, are the most common reasons for failure.
You mentioned procedures to remove clots. Are those common?
Traditionally, open surgical removal of deep vein clots, thrombectomy, has been performed more often in Europe than in the U.S. However, there's growing interest here in the minimally invasive catheter-based techniques, sometimes called percutaneous mechanical thrombectomy, PMT. These involve using specialized catheters that can either break up and aspirate the clot, like the Bacchus device mentioned, or use high-pressure saline jets combined with clot-dissolving medication, like the angiojet system, to remove the thrombus.
Do they work well?
These methods tend to work best for relatively fresh, softer clots rather than old, scarred blockages. The long-term outcomes compared to anticoagulation alone or other treatments are still being actively studied and debated. Patients almost always need to take blood-thinning medication, anticoagulation, for a period after any thrombectomy procedure.
What about venous bypass surgery? When is that used?
Venous bypass surgery, creating a detour around a blocked segment, is usually reserved for more extensive or chronic obstructions that aren't suitable for stenting. It's often best done using one of the patient's own veins, an autogenous conduit, as the bypass graft, if a suitable one is available. Where the bypass is created depends entirely on where the obstruction is located. For example, a femoral bypass might be used for a blockage in the iliofemoral vein on one side, using the saphenous vein from the opposite leg, carefully orienting its valves to ensure blood flows in the right direction towards the heart. Other configurations are possible depending on the anatomy.
What about just tying off or removing the greater saphenous vein, GSV? Is that ever done for obstruction?
Well, in some specific cases where there's an outflow obstruction, but the main symptomatic issue seems to be secondary insufficiency or high pressure caused by reflux down a concurrently blocked or incompetent greater saphenous vein, then a partial ligation and stripping removal of the GSV, usually just down to the knee level, might be considered as part of the overall management. However, it's absolutely crucial to know precisely where the main sources of reflux and obstruction are before considering this. Stripping the GSV won't help and could even be harmful if the primary problem lies within the deep venous system. You need a proper evaluation first.
So before any surgery for venous insufficiency, especially reflux, it sounds absolutely critical to have a thorough evaluation to pinpoint exactly where the backward flow is coming from. What kinds of tests are typically used for that detailed assessment?
Yes, a detailed preoperative evaluation is essential. Several tests are readily available to evaluate venous reflux accurately. These include ascending and descending venography, which are X-ray studies using contrast dye, less common now, duplex ultrasound imaging, the mainstay, and sometimes venous photoplethysmography, PPG, used with sequential tourniquet placement.
How does PPG with tourniquets work?
Venous PPG with tourniquets involves measuring the venous refill time after exercise, first without any tourniquets, and then repeating the measurement with tourniquets applied at different levels, example above knee, below knee, to temporarily block flow in the superficial veins. By seeing if the refill time normalizes, gets longer, when the superficial veins are compressed, you can help determine if the reflux is primarily in the deep system, the superficial system like the GSV, or involves incompetent perforator veins.
But duplex is still key.
Yes, duplex ultrasound provides the most detailed anatomical assessment of both the superficial and deep veins, specifically identifying the location and duration of reflux segment by segment. Often, both PPG, for overall physiological assessment, and duplex, for detailed anatomy, are used together to get the most complete picture before planning intervention.
What about venography? Is it still used?
Descending venography might still occasionally be used to specifically evaluate the competence of the valves in the major veins closer to the body's core, like the femoral or iliac veins, especially if deep vein valve surgery is being contemplated. Both venography and duplex imaging can also identify any areas of narrowing or stenosis in the venous system. While duplex imaging has largely replaced venography for routine diagnosis because it's non-invasive and provides excellent detail, venography might still have a role in some complex cases or when planning for surgical bypass or valve surgery. A key point with duplex, though, is that its accuracy can be very dependent on the skill and experience of the vascular technician performing the scan.
Okay. Now, what about that deep venous insufficiency, specifically caused by damaged or incompetent valves in the deep system itself? Are there reliable surgical ways to actually repair or replace those deep vein valves?
That's really the holy grail for severe deep venous insufficiency, but it's also the most challenging area surgically. Research is still ongoing, and as the source mentions, we don't yet know exactly how many functioning valves are needed or precisely where they need to be located in the deep venous system to fully restore normal function and reliably prevent ulcer recurrence long term.
But there are procedures being done.
Yes, there are several surgical techniques that aim to correct incompetent deep vein valves. These include inserting specifically designed artificial venous valves, though none are widely approved or used yet, transplanting a segment of vein that contains a working valve, usually taken from the patient's armpit area or upper arm vein, into the affected leg vein. This is called autogenous vein valve transplantation, and various methods for directly repairing the patient's existing damaged valves, direct valvuloplasty.
Tell me more about the valve transplant.
With autogenous valve transplantation, A segment of vein containing a competent valve is carefully harvested, usually from the axillary or brachial vein in the upper arm. This segment is then grafted into the venous system of the affected leg, often the popliteal or femoral vein, making absolutely sure the transplanted valve is oriented correctly to allow upward blood flow towards the heart. Patients typically need to take blood-thinning medication after this type of surgery.
How well does it work?
The initial results in terms of ulcer healing can be quite promising, with some studies reporting around 75% of ulcers healed at 12 months. However, maintaining that success long-term has been a challenge, with success rates sometimes dropping off after a couple of years, although they may stabilize after that. The data is still somewhat limited.
What about repairing the existing valves, valvuloplasty?
Direct valvuloplasty aims to repair valves that are incompetent, mainly because the vein has become dilated, causing the leaflets to no longer meet in the middle. Techniques involve either directly suturing the edges of the valve leaflets together to tighten them, an internal repair, or, more commonly, externally supporting or reinforcing the vein wall at the level of the valve sinuses to help the leaflets coapt or come together more effectively, an external repair or buttressing. There are various techniques for external repair. Direct valvuloplasty techniques can also sometimes be used to repair transplanted valves that have become dilated over time.
Are there other approaches?
Yes, there have been variations of the transplantation technique. A historical procedure called the Sothakis silastic sling involved placing a sling around the popliteal vein designed to compress it during walking, but this often lost its effectiveness over time as the sling became incorporated into scar tissue. More recent and technically complex techniques, focusing on actually constructing new valves, neovalve construction, or performing intricate valve repairs, have shown high rates of ulcer healing, over 88% in some reports, when performed successfully by experienced surgeons, but these are not widely available. And the development of truly effective prosthetic, artificial venous valves, like the titanium double leaflet system mentioned as being in development, also holds promise for the future.
But even with these advanced surgeries,
Adequate compression therapy is still necessary, both before and after, with essentially all of these surgical treatments for deep venous insufficiency. Surgery doesn't eliminate the need for compression in most cases.
what are those perforator veins, the ones connecting superficial and deep? If they're incompetent, is there surgery for them?
Yes, addressing incompetent perforator veins has been a focus for a long time. A historical major open operation called the Linton flap involved making large incisions to directly tie off these incompetent perforators, but it had significant risks, including wound healing problems, tissue slough, and prolonged recovery.
So what's done now?
A much less invasive approach developed later is called subfacial endoscopic perforator surgery, or SEPA. This uses minimally invasive techniques similar to laparoscopic surgery. A small camera, endoscope, and instruments are inserted through small incisions, usually below the knee on the inner side of the leg. Carbon dioxide gas might be used to create a working space under the fascia, the connective tissue layer. The incompetent perforators are identified and then ligated, tied or clipped or transected, cut using specialized instruments, often with electrocautery.
Is a C with PS common?
Advances in smaller scopes, better imaging, and instruments that allow coagulation and cutting in one step have improved the procedure, making it quicker, often less than an hour, and potentially suitable for an outpatient setting. The goal of SEPS is to eliminate the high pressure being transmitted from the deep system out to the skin surface via these refluxing perforators. However, the exact contribution of incompetent perforators to the overall picture of venous insufficiency and ulceration is still somewhat controversial among experts. But one meta-analysis mentioned found that SEPS, often combined with ablation of superficial reflux, resulted in ulcer healing rates around 88%.
Is there an even less invasive way to treat perforators?
Yes, another technique gaining interest, particularly in Europe, though not yet formally approved for this indication in the U.S., according to the source, is duplex ultrasound-guided foam sclerotherapy. This involves injecting a special foam sclerosant directly into the incompetent perforator veins, guided by ultrasound, to cause them to close off, essentially achieving the same effect as SPS, but without surgery. Further studies are likely needed to confirm its long-term effectiveness and safety compared to SPS.
Let's delve a bit more into that foam sclerotherapy. It sounds like a potentially useful, minimally invasive option, not just for perforators, but maybe for varicose veins too. How exactly does it work?
Right. Foam sclerotherapy is an evolution of traditional liquid sclerotherapy. It involves injecting chemical agents, called sclerosants, directly into the targeted veins. These chemicals work by intentionally damaging the inner lining, the endothelium, of the vein wall, causing inflammation and eventually leading to the veins scarring shut, narrowing, and ultimately becoming occluded or obliterated. It's a way to effectively treat veins with faulty valves or cosmetically bothersome varicose veins without needing major surgery.
Why foam instead of liquid?
Creating a foam from the liquid sclerosing agent, usually by mixing it rapidly with air, or sometimes CO2O2, has several advantages. The foam consistency increases the surface area of contact between the sclerosant and the vein wall. It tends to displace the blood within the vein more effectively than liquid, and it limits how much the agent spreads systemically once injected. This generally leads to better, more consistent results, often using a smaller volume of the chemical compared to using the liquid form alone.
What's the procedure like for the patient?
It's usually performed as an outpatient procedure, right in the doctor's office or clinic. Depending on the size and location of the veins being treated, local anesthesia might be used, and ultrasound guidance is frequently employed, especially for larger veins or perforators, to ensure accurate injection. After the treatment, the patient typically needs to wear a compression bandage or starking for a period of time, ranging from days to weeks, to help keep the treated vein closed and minimize inflammation.
How well does it work? Are there side effects?
Success rates in terms of closing the targeted veins can be quite good, often in the range of 70–80% or higher, and the treatment can be repeated if necessary. Side effects are usually mild and temporary. They can include temporary visual disturbances if a small amount of the foam air bubbles enters the general circulation, but this is usually transient. More common are local reactions like inflammation or tenderness along the treated vein, sometimes called phlebitis, localized pain or aching for a week or two, and occasionally a temporary dark pigmentation or mark on the skin over the treated vein. These symptoms can usually be managed effectively with simple measures like leg elevation, warm compresses, and over-the-counter anti-inflammatory medications like ibuprofen.
How is the foam made?
A common method for creating the foam manually just before injection is called the Tessari method, which involves rapidly mixing the liquid sclerosant and air between two syringes connected by a three-way stopcock. The foam created this way has a relatively short half-life, meaning it starts to break down fairly quickly, so the injection usually needs to be done within about a minute of preparation. There is also a commercially prepared, standardized Palaetoconol and Venous microfoam, brand name Verizolve, now Esclera injectable foam in the U.S., which underwent large clinical trials, Vanish 1 and Vanish 2, confirming its safety and effectiveness for symptoms of superficial venous incompetence, leading to its U.S. approval in 2013.
Can foam be seen on ultrasound?
Yes, a key advantage of foam is that it's echogenic, meaning it shows up very clearly, often bright white, under ultrasound because of the air bubbles it contains. This makes it ideal for procedures that require precise guidance using ultrasound. As mentioned, it's generally considered more effective than liquid sclerosants, especially for larger veins, requires lower volumes, and is suitable for treating veins of essentially all sizes, from smaller saphenous tributaries and reticular varicosities right up to larger varicose veins and even incompetent saphenous trunks in some cases, although thermal ablation is often preferred for the main saphenous trunks.
Is it used mainly for certain types of veins?
Ultrasound-guided foam sclerotherapy, UGFS, or UGES, is often used specifically to target those twisty saphenous tributaries that might remain after treating the main trunk, and also for treating incompetent perforating veins, as we discussed.
What are some of the specific sclerosing agents, the chemicals that are commonly used in these procedures, either as liquid or foam?
The most common sclerosing agents used, particularly for treating smaller veins like telangiectasias, spider veins, reticular veins, and small varicose veins, include sodium tetradecyl sulfate, STS, palidocanol, glycerin, and hypertonic saline.
How do they work differently?
They work by causing that endothelial damage, but through slightly different mechanisms. Some are osmotic agents, like hypertonic saline and glycerin. They work by creating a very high concentration difference that literally dehydrates or draws water out of the endothelial cells lining the vein, causing them to be destroyed.
Okay, osmotic dehydration. What about the others?
The others, like sodium tetradecyl sulfate and palidocanol, are classified as detergents. They work more like soap by disrupting the lipids in the cell membranes of the endothelial cells, essentially dissolving the lining and causing inflammation and thrombosis.
Are some used more than others?
Sodium tetradecyl sulfate, brand name Sotradicol in the U.S., is one of the most widely used and well-studied detergent sclerosants. The maximum recommended dose per session in the US and Canada is 10 milliliter of the 3% concentration, but it's typically used in much lower concentrations, from 0.1% up to 3.0%, depending on the size of the vein being treated. Polidocanol, formerly known as ethoxysclerol, now available as a sclera liquid and foam in the U.S., is another commonly used detergent. Hypertonic saline is probably the most common osmotic agent used in the U.S., typically in concentrations ranging from 11.7% to 23.4%. Glycerin, often mixed with chromium, chromated glycerin, for example, so Sclermar, is a potent osmotic agent popular worldwide, used in dilutions from 25% to 72%, but it's not currently commercially available as an FDA-approved sclerosant in the United States.
Okay. Are there any other endovenous techniques besides foam sclerotherapy that are used to treat venous disease these days, maybe newer ones?
Yes, the field is definitely evolving. There are several other minimally invasive catheter-based techniques available now. One category is mechanical occlusion chemically assisted ablation, sometimes called MOCA. A common example is the Claravane system.
How does MOCA Claravane work?
This technique uses a special catheter with a rotating wire tip. The catheter is inserted into the vein and the wire spins rapidly, which physically agitates and damages the vein's inner lining, the intima. At the same time, a liquid sclerosant solution is infused through the catheter right at the point of agitation. So it's a combination of mechanical disruption and chemical ablation.
What are the advantages?
A potential advantage is that it often causes less discomfort during the procedure compared to heat-based thermal ablation methods, like laser or radiofrequency, and may require less local anesthetic infiltration around the vein to mess in anesthesia. Its long-term durability compared to thermal ablation is still being evaluated in ongoing studies.
What about glue? You mentioned glue earlier.
Yes, another non-thermal, non-tumescent technique involves using a medical-grade cyanoacrylate adhesive, basically a specialized superglue, to seal the vein shut. The Venous system was approved in the U.S. in 2013 for treating incompetent saphenous veins. Cyanoacrylate glues have actually been used safely in medicine for closing other types of blood vessel malformations for over 30 years.
No anesthesia needed.
A major advantage is that it doesn't require the injection of large volumes of tumescent anesthesia around the vein, which can be uncomfortable for patients. Short-term outcomes reported in trials like the VCLOS study were similar to radiofrequency ablation in terms of vein closure rates, but again, more long-term data is needed to see how durable the closure is over many years. The procedure involves injecting small amounts of the glue sequentially along the vein while applying external compression. Its feasibility for closing perforating veins has also been studied, apparently without serious complications in early reports.
And then there are the heat-based methods you mentioned, laser and radiofrequency. Are they still common?
Oh, absolutely. Endovenous thermal ablation using either laser energy, EVLT or EVLA, or radiofrequency energy, or RFA, became incredibly widespread in the U.S. over the last couple of decades and really supplanted traditional surgical stripping as the primary treatment for saphenous vein incompetence for many surgeons. They are typically performed as outpatient, office-based procedures.
How do they work?
Both involve using ultrasound to guide the insertion of a thin catheter, either a laser fiber or an RF catheter, into the incompetent saphenous vein, usually accessing it near the ankle or calf. The tip of the catheter is carefully positioned just below the junction with the deep vein in the groin for the GSV, or behind the knee for the LSV. Then large volumes of dilute local anesthetic, called tumescent anesthesia, are injected all around the vein. This serves to numb the area, compress the vein around the catheter, and importantly, act as a heat sink to protect the surrounding tissues from the heat energy.
Then the heat is applied.
Right. Either laser energy or radiofrequency energy is then delivered through the catheter tip as the catheter is slowly withdrawn down the vein. This intense heat essentially destroys the vein wall and causes the blood inside to coagulate, leading to the vein sealing shut and preventing further reflux.
How effective are they?
Both EVLT and RFA have very high initial success rates for closing the treated vein, often over 95%, and good durability, with closure rates reported around 86–89% remaining at 4 years in some studies. There are also specialized devices available now for ablating incompetent perforator veins using these thermal energies, although they can sometimes be a bit more technically challenging to use than simply treating the main saphenous trunks.
What are the main advantages of these thermal methods?
The main advantages that led to their popularity are that they are minimally invasive, typically quick procedures, often under an hour, are generally well tolerated by patients under local anesthesia, and allow patients to avoid a hospital stay and the risks of general or spinal anesthesia associated with traditional stripping. They've become widely accepted for treating both symptomatic varicose veins and isolated saphenous reflux causing symptoms or skin changes. The complication rate is generally low, but one potential issue is that they typically leave behind a small segment of the vein near the deep junction and also the distal part of the vein, which could potentially reopen or develop new reflux pathways over time, recannulation or neovascularization. Some surgeons combine thermal ablation with limited surgical removal, phlebectomy, of associated varicose veins at the same time. Their office-based potential has been a major factor in their adoption.
Okay. What about when the ulcer itself is the main concern, and maybe it's very large or slow to heal despite good compression and addressing the veins? Are there any surgical approaches that focus directly on closing the wound?
Yes, in certain situations, particularly for large, chronic, but otherwise healthy-looking venous ulcers, meaning good granulation tissue, no infection, where the underlying venous issues have been adequately addressed as much as possible, applying a split-thickness skin graft might be considered to speed up closure.
Skin grafting. Does it work well?
It can work, but it's unlikely to be successful or durable if there's still significant, uncontrolled venous hypertension present. The graft often just won't take or will break down again quickly, even with ongoing compression therapy. So addressing the underlying venous physiology is still paramount.
What about those bioengineered skin substitutes?
Right, bioengineered human dermal substitutes are another option sometimes used for difficult-to-heal venous ulcers. These products, often derived from human or animal tissues or created synthetically, can act as a scaffold or framework for the patient's own skin cells to grow into, essentially helping to regenerate the dermal layer. Some may also contain growth factors or living cells intended to actively stimulate healing.
Are they a common treatment?
They can potentially hasten wound closure in some challenging cases, but they are generally very expensive, and again, they are unlikely to work well long-term unless the underlying venous hypertension is controlled and the wound bed is properly prepared. Even when they initially work, the rate of ulcer recurrence can still be relatively high if the underlying venous disease isn't managed aggressively with lifelong compression.
It certainly sounds like modern venous care has many more options now, beyond just the old Una boot and vein stripping surgery.
Absolutely. The understanding of the disease and the range of diagnostic and therapeutic tools available have expanded dramatically. Better, more tailored treatment paradigms are definitely emerging, combining wound care, compression, lifestyle changes, and these various minimally invasive and surgical procedures when appropriate.
This has been an incredibly detailed and really helpful discussion covering so much ground. To try and bring it all together now, what would you say are some of the most important key takeaways that people should remember about venous disease and venous leg ulcers?
Okay, key takeaways. I think the absolute most important thing to understand is that chronic venous insufficiency, once it develops, is generally considered a permanent, lifelong condition. Therefore, patient education is absolutely vital. Patients need to understand their condition so they can effectively manage it long-term and adhere to the necessary treatments, especially compression.
So, education and lifelong management. What else?
Second, actively promoting good venous return is crucial. This means emphasizing things like elevating the extremities above heart level for periods each day and committing to lifelong external compression, usually with prescription-grade stockings or sometimes bandages as prescribed.
Okay, elevation and compression, lifelong.
Third, protecting the skin on the lower legs from any kind of trauma is really important. Because of the underlying condition and potential swelling, even small cuts, scrapes, or bruises can quickly progress to larger wounds or ulcers that are then very slow and difficult to heal. Patients need to be vigilant and seek prompt care for any skin breaks.
Protect the skin. Got it.
Fourth, engaging in regular leg exercises to activate that calf muscle pump is beneficial. This includes simple things like ankle pumps or calf raises, especially during long periods of standing or sitting, and remembering to elevate the legs whenever possible when sitting down.
Keep moving, keep pumping.
Right. Fifth, successfully managing venous ulcers requires a strong commitment from the patient and a good understanding of the underlying pathophysiology why this is happening. It's a partnership between the patient and the healthcare team.
Team effort.
Sixth, while venous reconstruction surgery is a promising area, especially for deep vein issues, it's still evolving and not suitable for everyone. Seventh, venous ulcers almost always require external compression as a fundamental part of their treatment plan. Eighth, while there are a huge variety of wound care products available, there's currently no strong evidence that any single product is significantly superior to others for healing venous ulcers when adequate compression is used. Therefore, practical factors like ease of use and especially cost become important considerations. Ninth, surgical treatments for deep venous insufficiency do exist, like valve transplant, repair, bypass, stenting, but they are complex and reserved for specific situations.
And the main point again.
And finally, to reiterate, the mainstay of care for the vast majority of patients with venous insufficiency and ulcers remains appropriate, graduated external compression applied either with stockings or layered bandaging systems. Clinical competence in selecting and applying compression correctly is absolutely crucial for patients to receive the intended benefit and promote healing. When used properly, compression is safe, highly efficient, and cost-effective.
That's a great summary of the key principles. Now, to put all of this into a real-world context, the source provides a very illustrative case study of an 82-year-old woman. Let's call her Mrs. MC. She had a history of recurring superficial ulcers on her inner left ankle, presumed to be due to venous insufficiency. She'd experienced some spontaneous healing in the past, but had recently needed compression therapy at a wound center. Her current ulcer had been present for over 8 months, and the skin around it was described as macerated, soft, and broken down from moisture and weeping. Despite being independent, living with her daughter, having adequate nutrition, and being compliant with leg elevation and past use of compression hose, she was referred for a vascular surgery evaluation because the ulcer just wasn't healing.
Okay, a typical challenging case.
Right. On exam, she had no palpable pedal pulses in her left leg, which might raise concern, but she reported no symptoms of claudication, pain with walking, or rest pain. She had a remote history of smoking, but was otherwise healthy except for hypertension.
So the first step would be that vascular testing.
Exactly. The vascular lab performed tests. Her ankle brachial index, ABI, was actually greater than 0.95 in both legs, with normal triphasic arterial signals, indicating good arterial flow, ruling out significant arterial disease as the primary cause. However, her venous refill times were abnormal, quite short, 12 seconds on the left and 15 on the right, indicating rapid refilling due to reflux. When they used tourniquets, the test pointed towards isolated incompetence of the greater saphenous vein, GSV, in both legs as the main source of the reflux. Duplex ultrasound confirmed this. No evidence of any deep vein thrombosis, DVTs, but significant reflux, lasting more than 0.5 seconds, was found in the left proximal femoral vein near the groin and throughout the entire length of the left GSV. Reflux was also found throughout the entire right GSV.
Ah, so significant superficial reflux, especially on the left, the side with the ulcer.
Precisely. Based on these findings, the recommendation was performing venous ablation of the left GSV. Can you walk us through why that approach was chosen for her and what the outcome was?
Sure. In Mrs. MC's situation, the extensive incompetence found throughout her left GSV was identified as the most likely primary cause of her recurring ulcers and the chronic skin changes she was experiencing on that ankle. Even though she also had some reflux detected higher up in the left proximal femoral vein, the GSV was considered to be the predominant source of the dermal hypertension, the high pressure affecting her skin in the ulcer area.
So targeting the GSV was the key.
Yes, the thinking was that ablating or closing off the incompetent left GSV, combined with continued use of support hose, would significantly reduce the venous pressure in her lower leg, improve her symptoms, and allow her ulcer to finally heal. Given her age, 82, and her stated desire to avoid a hospital stay and major anesthesia, radiofrequency RF endovenous ablation was chosen. This is a minimally invasive procedure that can be performed right in the office or clinic setting under local tumescent anesthesia.
What did the procedure involve for her?
As described, the RF fiber was inserted into the lower part of her left GSV, near the calf, guided carefully by ultrasound imaging. The tip was positioned about 2 centimeters below the junction where the GSV meets the common femoral vein in the groin to preserve flow from other veins joining there. Then the tumescent anesthetic solution was infused all around the vein along its length. Finally, the RF generator was activated to deliver heat energy in cycles as the fiber was slowly pulled back down the vein, effectively sealing it shut.
And after the procedure?
Post-procedure, she was placed in a thigh-high compression stocking providing 30-40 millimeter Hg of pressure. She wore this continuously for the first 72 hours and then just during the daytime, non-sleep hours, for the following 7 days. Follow-up duplex ultrasound scans were performed later to confirm that the GSV had indeed been successfully ablated, closed, and, importantly, to rule out any procedure-related complications like DVT.
And the outcome? Did the ulcer heal?
Yes, the case notes state that Mrs. MC did very well. Her chronic skin condition improved and the ulcer healed completely, although it took about 2 more months after the ablation procedure. Crucially, she now wears knee-high 30-40 millimeter Hg compression stockings religiously on both legs every day. Her right leg, which also had GSV reflux but no ulcer, has remained asymptomatic.
That's a fantastic outcome and really illustrates how targeting the underlying venous reflux, combined with that essential long-term compression therapy, can effectively manage even very chronic and difficult venous ulcers.
It really does. It highlights the importance of proper diagnosis and a combined treatment approach.
Okay, now before we finish up this deep dive, the source includes a quick show what you know quiz, just 4 questions to recap some main points. Let's quickly go through those. First question. The primary cause of venous ulcers is A, venous stasis, B, venous hypertension, C, embolic phenomenon, or D, varicose veins. What's the answer there?
Based on our discussion, the primary driver is B, venous hypertension.
Correct. Second, the ankle brachial index, ABI, is a test that indicates a loss of adequate blood flow, perfusion, in the lower extremity. Is that statement A, true, or B, false?
That is A, true. A low ABI indicates arterial insufficiency.
Right. Third question. The single most important component of treatment for venous ulcers is A, moist wound healing, B, antibiotics, C, compression, or D, surgical revascularization.
That has to be C, compression. It's the cornerstone.
Absolutely. And finally, number 4. The single most detrimental or harmful activity for a patient with any type of vascular disease, arterial or venous, is A, walking into the pain, B, sleeping with legs hanging down, C, use of nicotine products, or D, failing to check their pulses.
While the others aren't ideal, C, use of nicotine, is widely recognized as extremely detrimental to vascular health overall.
Exactly right. Excellent. That really helps reinforce those key concepts we've spent our time discussing today.
Yeah, a good quick review.
So to sum everything up, venous disease and the development of venous leg ulcers are clearly complex conditions, involving intricate physiology and multiple contributing factors. But the good news is that they are definitely manageable, although often requiring long-term commitment. Compression therapy stands out as absolutely central to effective treatment and prevention.
Couldn't agree more. Early and accurate diagnosis, based on a good history, exam, and appropriate vascular testing, along with consistent adherence by the patient to the recommended therapy, especially compression and lifestyle changes, are truly crucial for achieving good outcomes and preventing recurrence.
We really hope this deep dive has helped to clarify some of the complexities surrounding venous disease and provided you, our listeners, with a more solid and practical understanding of how it develops and how it's managed.
It's a vast topic for sure.
It really is. And if any specific area we touched upon today has particularly sparked your interest, perhaps the different types of sclerotherapy, the nuances of choosing and applying compression bandages, or maybe the latest advancements in surgical or endovenous techniques, we strongly encourage you to explore the resources we've based this discussion on, like Wound Care Essentials, in more detail.
There's always more to learn.
Always. And finally, to leave you with something to think about. Considering how incredibly common vein abnormalities like varicose veins are, and the distinct possibility that many venous ulcers may go unreported or misdiagnosed, what proactive steps can individuals take in their daily lives to be more mindful of and actively care for their vascular health, perhaps even before problems arise? That's something to consider until our next deep dive.